This program is a presentation of University of California Television. Your support makes UCTV's programming possible. Contribute online at uctv.tv/support. Check out our YouTube original channel, UCTV Prime, at youtube.com/UCTV Prime. Subscribe today to get new programs every week.
Is going to present for us next. It's difficult to introduce her because even though I've known her for several years now, I'm still unclear how to pronounce her first or last name. So I'll just call her MG. And
Thank you, Dr. Eichler. All right, so it's either Marlene Grenon or Marlène Grenon, but I always say, like, as long as I understand I'm being talked to, it's fine. So I'm going to talk today, try to follow the previous really excellent talk and talk about a little bit about screening for ischemia in the diabetic foot. There's no disclosure for this talk, so I'm going to ask you the question. In the diabetic patients, what is the pattern of atherosclerotic disease, and which one of the following is false? So I think we can start the counter. See what is exactly. So like the answer is one here. So severe inflow disease patients, diabetic patients may have inflow disease, but usually it's more like tibial disease, and we'll go through that in the during the talk. And in diabetic patients with neuropathy, which would be the best screening tool, the one that would have the highest sensitivity? So either the pulse exam by the vascular surgeon, the ABI with exercise, the toe brachial index, or the pulse volume recording. Very good. So the toe brachial index is the one that has the highest sensitivity, but the pulse volume recording is actually very good also, as you'll see. So I'm going to try to discuss with you today why screening is important, how it can be accomplished, and how we could use the results to optimize management. So as we're all familiar with, PAD is a public health issue, and in the primary care setting, it could be up to 1/3 of the patients that suffer from this disease. Risk factors, as were discussed this morning, include smoking, diabetes, hypertension, but as you can see, diabetes here is one of that has a very high relative risk. And some numbers that were discussed in detail by Dr. Andros, but there's more than 23 million diabetics in the US, and worldwide more than 350 million patients that suffer from this disease. Once patients have diabetes, their risk of CAD, cerebrovascular disease, or PADs up by 4-fold. 1 out of 3 patients with diabetes that are age 50 or more have PAD. Once patients have diabetes and neuropathy, 7 to 10% of them will develop an ulcer annually. If this is compounded with PAD, it goes up to 25 to 30%. And then diabetes is the #1 cause of amputation in the US. If we look at the age-adjusted risk for amputation, it's 28-fold higher. So diabetic with PAD are at significant increased risk for mortality and limb loss. Let's look a little bit at more numbers. So you could see here that with impaired glucose tolerance and diabetes, your risk of PAD is higher. And the next slide actually demonstrates that once CLI is established or patients have an ulcer or related to that, the mortality at 6 months is 20%. Compounded with diabetes, this is much higher with a mortality of 50% at 6 months. This is coming here from our own data with the Heart and Soul study looking at patients with coronary artery disease, and it demonstrates that in that setting with coronary artery disease, if you have PAD on top of that, you have a double risk of having a CVD event or dying from it. And actually the factor that explained the most this excess risk was the hemoglobin A1C. So diabetes in that setting is a major problem. Again, here demonstrating a classical slide demonstrating that patients that have diabetes are more at risk of losing their limb. So why is that? Could that be like we've had like quite a good, an excellent actually insight into that in the previous presentations. But diabetics have a unique pattern of peripheral atherosclerosis, less frequent inflow disease. The SFA is often spared. More severe tibial disease with the pedal vessels often spared also. There's less chance of collateralization, and there's also a chance of having stenosis in the collaterals. The pathology is both an atherosclerosis but also a medial calcification, and with the coexistent neuropathy that has profound effect on the foot in the setting of all those metabolic abnormalities. And those are typical slides, typical like disease pattern here that you could see in terms of sparing of the inflow, like pretty clean, like SFA, popliteal, with the tibial disease being like more profound here, and then reconstitution of the DP. So PAD is a different and more virulent disease than the diabetic population, and then screening becomes much worthwhile. How can we accomplish that? Well, what are the goals of the non-invasive screening? Confirm the presence of disease, be able to provide reproducible physiological data with regards to disease severity, document the location of the disease and the importance of the lesions, prepare a plan for intervention, and being able to follow after we've performed an intervention. For one mistake made for not knowing, 10 mistakes are made for not looking. So the first place would be to do a physical examination, and we should not be fooled by the fact that the foot may appear pink and relatively warm, which is very common in the presence of arteriovenous shunting. We often have debates in terms of like what's the best screening tool. Here's different tools that we could use, like we could look at hemodynamic or physiological measurement with the ABI or the toe brachial index, the segmental Doppler pressures, pulse volume recordings. We could look at tissue perfusion, and then again confirm like with some anatomic imaging. The American Diabetic Association recommends to screen diabetic patients that are over the age of 50, as well as younger insulin-dependent patients with other vascular risk factors with the ankle brachial index. And we put together a little video a few years ago in the New England Journal of Medicine that we use actually in clinic, and to educate the nurses and the medical students and the residents in terms of how to do the ABI. So the ABI, the normal range, as you're all familiar with, is 0.9 to 1.3. The cutoff for diagnosis of PAD is less than 0.9. However, there's some studies that suggest that in diabetic patients, we should use a cutoff that is slightly higher, like 1 to 1.1. There is like an intra-observer variability that is present there. There's different methods of calculating the ABI, but as per the different society, we should be using the highest pressure in the leg and the highest pressure in the arm. What happens with the ABI in diabetic patients? Well, the sensitivity and specificity drop, like sensitivity 63 to 100%, specificity 85 to 97%, but when this is compounded with neuropathy, it goes even lower. In another study by Shang and colleagues, the most significant factor affecting the validity of the ABI was diabetes. So what can we do? Other tools that exist, like the toe brachial index is one of them. It is simple, can be used in the vascular or done in vascular surgery lab with a normal, like being more than 0.75. Severe ischemia is present when it's less than 0.25, and with an absolute pressure of less than 30 millimeters of mercury, like the chances of healing, as we'll see, are pretty low. Segmental pressures are another tool that can be used for screening diabetic patients, and it also allows to locate or see where the disease is located. We could have pulse volume recordings that could be done, which are pretty good when the leg is calcified or the arteries are calcified. And then the transtarsal waveform is good for the foot healing. With regards to tissue perfusions, this is a method that can be used. It's a little bit more variable, can be with regards to room temperature, location of the probe. So from one setting to another, it can vary. But it's the rise in the TCPO2 can be used to predict who's going to benefit from hyperbaric oxygen therapy. Another tool that can be used is the laser Doppler, and this is a machine that we've just acquired recently at the VA, and a pressure of 30 millimeters or less would be an issue with regards to healing. Is there studies looking at what is the best? There's actually only a few studies. This was published in 2001, to be I or not to be indexed, so that's the question. So but in this study, the authors found that the majority of patients with diabetes, the TBI conveyed no advantage to the ABI for looking at perfusion in the limbs, except in the patients that had a fair amount of calcification, represented by an ABI of more than 1.3, which we would expect. In this study that was published a little bit more recently, the authors look at the sensitivity, specificity, accuracy of the different measures, screening measures in patients that had diabetes and no neuropathy, and patients that had diabetes and neuropathy. And in that setting, the TBI and basically the pulse volume recordings were the best measures for improved sensitivity. We have also other tools for screening, ultrasound, and then obviously if we want to confirm the diagnosis, we could go on to anatomic imaging. So what types of pressures do we need for healing? This is a classical study that demonstrated that for patients that had no diabetes or patients that have diabetes, at any type of ankle or toe pressure level, your patients with diabetes are going to have a much lesser chance of healing, and that basically underlined the problem in terms of healing with the same pressure. And this is the classical graph in terms of healing, and you could see that with toe pressures or TCO2 less than 30, basically your chance of healing is going to be much lower, around 50%. So with that, with screening, we should remember that in patients that have diabetes and with a foot ulcer, if there are no palpable pulses, even if there are Dopplerable pulses, those patients should be investigated. In an ulcer, a patient that has diabetic patient that has an ulcer that is stagnant, we should be investigating. We should trust the ABI when it's low, but not when it's high. And then if it's high or we're really suspicious, we should go on to more investigation like the toe pressures or perfusion assessment. So with that, how could we use these tools to best optimize management? Well, we have some guidelines from the American Heart Association, and these are for patients basically that are asymptomatic or that have atypical leg symptoms, and patients that have diabetes fall into those categories if they have no lesions because of their high risk of developing PAD. So in patients that have an increased like ABI, then the recommendations are to proceed with more like screening tools or screening tests. And then if we have abnormal results and confirmation of the PAD diagnosis, really optimizing like the risk factors in terms of like advice with smoking cessation, treatment of hypertension, treatment of lipids, treatment of diabetes with keeping the hemoglobin A1C less than 7%, and then like more pharmacological risk reduction. In the setting of critical limb ischemia, which we've discussed this morning, then there should be an early referral like to the vascular specialist in order to provide the best possible revascularization if the patient is a candidate for revascularization. And then like going on to surveillance like to make sure that there's no recurrence of the lesions or the ulcers. Now, like, what else from the standpoint of medical treatment can we do? Do we have some evidence that, being intensive like therapy would help? There is, but it's controversial. This is a study in 2008 that took 160 patients and provided multifactorial intervention in patients with type 2 diabetes. And they based their treatment on the American Diabetic recommendations. In this case, they kept the hemoglobin A1C less than 6.5. There's the fasting total cholesterol less than 175, the triglyceride less than 150, control of blood pressure, ACE inhibitors for microalbuminuria, and then low-dose aspirin. So this demonstrated that there was a significant reduction in the endpoints of death or like cardiovascular events altogether. Some of them included revascularization, and that was revascularization for lower limb ischemia and amputation. So there is an advantage, like in patients that do not have like an active lesion, to like really consider like intensive like multifactorial intervention. When I say controversy, like there's 2 more trials that were published like that year in the New England Journal of Medicine that included many more patients. Those trials look at glycemic control, intensive glycemic control in diabetic patient. In the advanced trial, there's a significant reduction in the primary endpoint, but that was secondary to a decrease in the nephropathy. However, in the ACCORD trial that was published the same year, there's no significant difference in the endpoint like of non-fatal MI, non-fatal stroke, and CVD death. And there's an increase in the mortality, which was thought to be secondary to hypoglycemic event. So again, like one should be careful in terms of like the like intensive therapy. Again, it was demonstrated this morning, diabetic rapid response team is really important, and that Dr. Fitzgerald and team demonstrated that some of the important points with that response team was the ability to perform hemodynamic and anatomic vascular assessment with revascularization if necessary, and then the ability to perform wound assessment and staging grading of infection in ischemia. At the VA, we have a protocol in place. We work very closely with the podiatrists. If PVD is suspected, like screening tests take place, and then like those patients are then referred to vascular surgery, where a vascular intervention and revascularization can take place if necessary. And at UCSF, there's also a very big effort for limb preservation with the Center for Limb Preservation, and dedicated Live Savage program with like inpatient and outpatient care, like combined clinics on Friday morning, and having the podiatry resident on the team, and the vascular surgery team. So overall, the results of the screening test can be used to optimize care, including risk factor management, appropriate referral, and then surgical revascularization. So what I'm going to leave you with this presentation in terms of take-home message is that patients with diabetes are at high risk of PD, as we've seen. Early referral and intervention is key. Non-invasive vascular testing is recommended in all patients with diabetes and foot ulcer. Image if non-invasive tests indicate ischemia. Ensure that medical therapy is optimized and then revascularized as needed to be able to improve distal perfusion and promote ulcer healing. All right, thank you very much.